right. Just going to wait a couple of more seconds to let people walk in. We'll get started at 6:04. For those of you who are coming in, it would be great if you can introduce yourselves in the chat. Would love to know where people are calling from or calling in from, your organizations or state, and then just why you decided to join us today. So in the chat, if you could just introduce yourselves, and the panelists and moderator can go ahead as well SAPHA staff, just your name, what state you're calling in from and your organization, and why you joined us today. And with that, we can get started. So welcome everyone. As a reminder, this session is going to be recorded. Please make sure that you are muted during the presentations, and any questions that you have, please put them in the chat. Minal will be asking the questions afterwards when we have the Q&A session. So today we have a great panel prepared on from awareness to action, advancing cancer prevention in South Asian communities. And I just wanted to start off with an introduction of SAPHA prior to that. So SAPHA is the South Asian Public Health Association. We're a national volunteer-run nonprofit. We envision better health and well-being for South Asians in the U.S. and the communities in which they live. And we do this through advocacy, collaboration, and communication. We advocate for South Asians in the U.S. on priorities that impact their health, such as cancer. We like to partner with community-based organizations, academia, policymakers, and different community stakeholders to communicate current and relevant South Asian public health knowledge and research. This is just our board of directors. We have an executive committee and then 5 additional committees: the research committee, communications, fundraising and outreach, education and professional development, and advocacy. Our committees are led by 2 co-chairs who also sit on our board of directors. And then each committee also has about 3 to 4 committee members that help push out a lot of this work that SAPHA has been doing over the years. We also have interns that come on throughout the year to help with very specific projects. Over the past few years, we have celebrated last year the 25th anniversary of SAPHA. We just completed 25 years. We've also developed a research hub and a compendium of disaggregated data, which I will show you on the next slide on where to find that. Last year, we also kicked off our Spotlight Series podcast, where we had interviewed past SAPHA board members and just talked over their career trajectories and where they are now. And we are going to be launching season 2 soon and expanding it beyond the SAPHA board members, just, public health professionals in the field. So if you're interested in being featured in that, please feel free to reach out to us. We also have been, for the past many years, sending out monthly newsletters that highlight the work that SAPHA has been doing, as well as, research that has been published on South Asian health and anything else that's relevant to the South Asian community. We've also spent the past 2 years working on a big health disparities report that is going to be released soon. And we are working on developing a Caring for a South Asian Patient Guide, which should also be ready by the end of this year. Lastly, we received a racial equity grant from the National Council of Asian Pacific Americans last year that's focused on combating health misinformation. And so a bulk of the work that we've been doing this year is really on that grant and understanding what that looks like in the communities. We are also sub-awardees on 2 NIH-funded grants, CARE 2.0, which is looking at enrolling Asian American, Native Hawaiian, Pacific Islanders, and for us specifically South Asians, in a repository that would essentially be available to people who are looking at Alzheimer's disease. And so we are hoping to get more South Asians enrolled in this study so that they can then be eligible for studies that are looking at aging, caregiving, and Alzheimer's disease. We are also a sub-awardee on a SEAL grant through University of Texas, and that is specifically looking at diabetes. We are also launching a national conference and gala planning committee. We are hoped to have a conference this year in November, which I will share the save the date in the next couple of slides. So on our website, you can find our South Asian Research Hub, which is essentially the equivalent of like a South Asian PubMed. You can go to Research Hub on our website, which is www.sapha.org. And you can filter by different South Asian ethnicities, South Asian groups, or specific terms related to South Asians. And it will essentially pull up all of the publications that are related specifically to that. And so hopefully this will be a great resource for researchers and students who are working on papers to connect you to the different papers that have been published on South Asian health. Also, in an effort to disaggregate some of the data, we've compiled essentially a table of different data sets that feature South Asians. So we have the data set listed, as well as what ethnicities are included in those data sets, where you can find it, what location, what health outcomes are included. And so you can find that in our new tab that we've added to our website called Disaggregating Diversity. Again, as a reminder, please make sure that you mute yourself. Please put any questions in the chat box, and then your questions will be asked by a SAPHA member at the end, for those of you who are just joining us. Just some things that you'll be seeing coming out from us in our newsletter or on social media in the next couple of weeks. We, in advance of ANHPI Heritage Month, we wanted to spotlight early career South Asian public health researchers and professionals who are doing outstanding work. We had sent out a link via our newsletter or email, and we'll be sending out a couple of more emails, and this will also be posted on our social media. But you can also just take scan the QR code that's on the screen to essentially either nominate yourself or nominate someone that you know who you would like to have featured throughout ANHPI Heritage Month. We also have a couple of more events that are coming up. We have an advocacy workshop focused on economic justice that's going to be happening in May. We have a careers in public health panel discussion that's being planned for June. And then we are going to be having a panel discussion related to Alzheimer's disease and related dementias in September. And then we also have a national conference and gala that is going to be happening in DC in November, right after the American Public Health Association conference. So this is the save the date. Please feel free to screenshot this. We will be sending out details and registration soon, but we will be having our gala on Wednesday, November 5th at 6 p.m. at the top of town in Arlington. And then the conference will be the next day, Thursday morning at George Washington University. So we really look forward to seeing you all there. If you're interested in joining our planning committee, please feel free to reach out to us as well. I will put our email address in the chat after this is done. And if you're interested in getting involved with SAPHA, you can sign up to be a committee member. So you can either scan that QR code, or if you go onto our website, there is an area where you can get in touch with us and also sign up to be a committee member. You can also partner with us if you are an organization. So feel free to fill out the form that's on our website and then email us at partnership@sapha.org. And lastly, make sure that you stay connected with us for all of our events. You can scan the QR code to sign up for our newsletter, follow us on our different social media accounts, or just visit our website. And with that, I would like to introduce our moderator today, Minal Patel, who is a SAPHA board member. She is the co-chair of the fundraising committee, and she's also director of strategy and operations at Isabel Inc. So I will stop sharing and turn it over to Minal to take over. Thank you.
Hi, everyone. I have the pleasure of introducing our wonderful panelists that are going to go through and showcase the current cancer disparities in the South Asian communities, focusing on barriers to prevention and screening. We have Dr. Salma Shariff-Marco, who is the professor of epidemiology and biostatistics at University of California, San Fran. We have Nishith, who is the director of federal advocacy at the American Cancer Society and Cancer Action Network. We have Farshid, Haque, who is the president of Sacramento area Bangladeshi American Association. And then we have Dr. Swaminathan Iyer, who is a professor of medicine at MD Anderson, focusing on lymphoma and myeloma, along with the president of the Indo-American Cancer Association. So welcome, panelists, if you can mute yourself. I wanted to get started with you guys just introducing yourselves, and can you each share a bit about your background and what inspired you to focus on cancer prevention and overall health equity in the South Asian communities, particularly in the South Asian community context? Salma?
Yeah, sure. So for me, it's, I think, growing up here. Grew up in Southern California. I see there are folks from SoCal on the chat. I think, you know, all our families have probably been impacted by cancer. Mine has certainly, and how my family reacted to cancer diagnosis and how we talked about it, and sort of really the lack of information and understanding of the resources that we had available to us to prevent cancer, detect it early, get timely treatment, are all things that sort of stuck with me. And as I came into public health from a professional standpoint, I just wanted to better understand, how can we change this moving forward? How can we do better for our community? So I started very early on doing outreach with the American Cancer Society, specifically focused on engaging South Asian communities in New York, where I was, and then went on to, get my PhD and really think about the multi-level factors that are driving and shaping health inequities, and considering sort of race, ethnicity, socioeconomic status, immigration, and really the intersection that comes at play for South Asian communities. So I'll leave it at that and allow one of the other panelists to introduce themselves.
Thank you, Salma. Nishith?
Thanks, Minal. Thank you all for being here tonight. Similar to Salma, I grew up in Chicago, but beyond that, I think everything she said, I would echo. I think the one kind of caveat or edit I would make is that it's not only how we talk about cancer, but it's how we don't talk about cancer in our community also. And I think, for a lot of families, a lot of members of the community, it's still cancer. And it's a very dirty word, or a very loaded word at least. So I think kind of just removing some of that stigma, making more information accessible. And just for a very long time, I think up until about 5 years ago, there was no real discussion of the South Asian community as a community in itself. It was always lumped into the broader then AAPI, now AANHPI community. And while we are a part of the community, there are unique factors and unique risks that come with the South Asian community. And I think we're just starting to see some more discussion and data on that. So I think it's a really important factor I wanted to highlight. And I think we also have an aging community, in the sense that a lot of our parents and grandparents are facing these risks, facing these challenges, and may not have the information that they need to make an informed decision. So I want to work towards making that information more accessible and making it easier for people in the community to really understand what they're facing, what their options are, when they should be getting tested or screened, or what kind of preventative measures they can be taking. So I'll leave it at that.
Thank you. Farshid?
Hi, so my story is actually very personal, because I actually lost my dad to cancer at a very young age. I was 13 at that point. And then over the years, I lost my aunts, my uncles. So, and then in my current capacity in the, we call SAPHA, the acronym for organization SAPHA board, we have very many different community members approach us, especially when they need help, accessing healthcare, and so we help with outreach, we help with free medical service, and in the course of that, we have learned a lot of stories, heartfelt stories. So all of that has sort of motivated us to get involved with public health issues and cancer in particular. So that's a big reason why I'm doing this. So, yes.
Thank you, Farshid. Dr. Iyer?
Thank you for this invitation, and it's so good to be with such passionate and committed individuals to improve the lives of not just South Asian communities, but also the people around. I am, so my journey starts back as a medical student. When we first learned about the second generation and third generation studies of the Japanese population, the most popular the epidemiological studies that are often quoted on how genes, environment, modulation can make a huge difference. And because the first generation Japanese, didn't have certain issues, the second and third generation Japanese had a lot of colorectal cancers, as an example. And it's one of the first few epidemiological studies. Of course, we went into oncology for a personal reason, like Farshid, cancers in the family. Having seen both sides of this, both as healthcare provider and a caregiver and the family and somebody, having family members affected. So it gets you to the point of trying to make a difference, so, go to the root of the problem, and got involved with the Indo-American Cancer Association, which was an ambitious effort to bring all the Indo-American folks together to raise awareness and to do things in the subcontinent in India. And we had three signature programs. One was the easier one, which is education, trying to improve the capacity building, trying to bring folks here to the US to learn techniques, whatever the area might be, whether it's surgery, pathology, oncology, radiation oncology. The second one was palliative care, and which was very, very poignant because back in India, it was very hard to get morphine. You need 5 licenses, and working with some of our partners in Pallium, India, Dr. Rajgopal, who actually went to the Supreme Court and got the ability to give morphine to dying patients, which is not a possibility back in India. And the third signature program that we did was to work in tribal communities with WHO and to do. We started what started as a cervical cancer prevention program. Became a much larger cancer and general healthcare prevention program. So all these have taught me a lot. Though I'm still a practicing oncologist, and I think if you look at the whole curve of carcinogenesis, we focus so much on when the cancer actually happens, but there's a lot of efforts that can go towards before it actually happens, biologically speaking, and how can we prevent those? And there are like 6 or 7 cancers that we can do so effectively, but there's still so much gaps in thought and awareness and education to try and get those things addressed. And then you have the other cancers, you don't know why it happens. So it's a continuing effort, and I think I'm happy to be here. Thank you.
Thank you. I think the first question that comes to mind in terms of awareness and disparities are, what are the current unique trends or disparities in cancer incidence and prevalence among the South Asian communities? Salma, do you want to comment on that?
Yeah, so I think, there are unique cancer burden in our communities. However, the challenge for us is being able to really characterize that for all the groups represented by our South Asian label, right? And so I think for those of you who are not familiar, American Cancer Society actually last year did a facts and figures focus on Asian Americans and really tried to present as much disaggregated data as is currently available. So probably will come as no surprise. We have data primarily speaking for our Asian Indian and Pakistani population within the South Asian population groups. And so what we see is that while, yes, prostate cancer and breast cancer are the most common cancers also for our South Asian populations represented by these two groups, we do see that oral cavity and pharynx cancer is on the top 4 for our males. And then thyroid cancer and uterine corpus cancer are among our top 4 for females, which is a little different than the general population. For Asian Americans overall and for Asian Indians, cancer is the leading cause of death in the US. This comes as a surprise to many people because we think of cardiovascular disease as the #1 killer. But for our population groups, cancer is the leading cause. And so it's really, an opportunity here to think about early detection and prevention strategies to improve health for our communities, right? And for males, lung cancer is the leading cause of death, followed by prostate, pancreas, and colorectal cancer. And for females, breast cancer is the leading cancer cause of death, followed by lung, ovarian, colorectal, and uterine cancer. So you can see they somewhat track with cancer incidence. So, that's the cancer burden, thinking about new cases or incidents and mortality or deaths. I think the other underlying thing is that we also fall prey to the model minority myth, right? That Asian Americans in general are tagged with. But when we look at some of our risk factors and our preventive behaviors, we see that actually we aren't a model minority with respect to that, right? So our communities actually have the lowest screening rates for cancer. So we're not taking advantage of opportunities to find cancers early and treat them, right? And have better survival, better survivorship outcomes. We also have low participation in things like vaccination, Hep B testing, which can also help to get us on a better trajectory and improve, lower our cancer risk and improve our cancer burden. So I think there's certainly opportunity for us to do better. Just two other risk factors I'm going to touch on, and then I'll hand this over, is actually being overweight. So we actually have a higher proportion in our population group that are identified as overweight or obese. And this, I think, is using, so there's sort of two ways of assessing overweight and obese, the one that's used for the general population. But as many of you may know, there's an Asian specific cut point. So if we apply that, we're probably even higher. So, accounting for different body styles across different racial ethnic groups, and then healthcare insurance, right? We tend to be an underinsured population as well. So getting into the healthcare and engaging in these preventive behaviors, there's barriers there as well.
Wow, that was great. Thank you, Salma. Nishith and Farshid, I think for you guys, can you talk a little bit more about what are the current unique trends? What are some of the major barriers that South Asian communities face in accessing cancer screenings and the prevention methods?
Yeah, I think Salma's touched on one of the biggest ones, which is access to quality, affordable healthcare. I mean, regardless of what the current law is and what it has been for 15 years now, we still face that problem in too many communities across the country, including South Asian community. I think there's also the factor of cultural stigma. I alluded to this in my earlier comments, but cancer is still seen as a dirty word for a lot of people in our community. So there's a fear factor, of course, with cancer, because it is a scary word and a scary set of diseases, but there's a fear factor and a stigma that comes with even finding out if you have cancer, because there's a sense of ignorance is bliss to a degree. And of course, with a lot of other first generation, second generation communities, there's a language and cultural barrier too, that medical professionals may not know how to approach South Asian patients, even if many of them are South Asian themselves. And there's a cultural factor in how you talk about a cancer, talk about a chronic disease like that. And another kind of last thing I'll touch on, and Salma also mentioned this, is data disaggregation. I mean, if you don't know where the problem is, it's hard to address a problem. And like I said before, we've been lumped into a broader group for such a long time. And I think Salma alluded to this also with the Indian Pakistani data, that there's not real finite and reliable data on South Asian communities outside of that bigger, broader bucket. So it makes it hard to know what problems you're facing and what needs to be done to address them if you can't identify the problem in a detailed way. Michelle, I'll turn it over to you.
And if I can add, some of the unique barriers, specifically in our area, this is in the Sacramento part, for example, is just commuting, for example. You'll have a lot of these families, and they're high-skilled families, but some of the families also have migrant households, which means you also have members who work in the service sector and families who are primarily service sector. What happens is their schedules then do not permit them to access healthcare when the providers are open, for example, or even when their parents need help, elderly parents, they'd have to take time out and they cannot take time off from work. So there are unique challenges in that respect. In other words, of course, what Nishith and Professor Shariff-Marco just touched on. So.
And then how do social determinants of health, and then including the cultural beliefs and stigma and gender roles, influence these health-seeking behaviors related to cancer prevention in the South Asian communities? And what are some ways that we can intervene to improve upon those? Salma, would you be able to comment?
Yeah, so, I think the structural and social drivers of health are complicated, and the interventions that we need to develop, include things all the way from policy to multi-level interventions. I think having community at the table as we design these interventions and address these barriers is critical. But I do think, there's also an element of mistrust, distrust, right, with the healthcare system and trustworthiness of the healthcare system that comes into play. I think we've already heard having resources and the ability for patients to navigate healthcare systems in their languages of preference, right, with material that's relevant for them and acknowledges their culture and their practices and their beliefs, I think is also really important. So, but I think, data and information that represents the communities that we want to have engage in the system is critical. And that's what we're trying to do, is to make sure that we are able to help disaggregate the data in a meaningful way that represents the people and can, speak to them. So, I think it's multi-pronged policy, epidemiology data, as well
Absolutely.
as interventions. Yeah.
Yeah, absolutely. And I think awareness, number one, just me learning today of how prevalent prostate cancer and even colon cancer is among South Asian men. Working in a cancer setting, I had not known that, right? Because what you learn in terms of even when you work in the cancer care industry is you don't learn the South Asian incidence and prevalences. So data disaggregation and the need to have that data aggregate is very important. What are some strategies that healthcare providers and research and community organizations can use to improve such cultural understanding and then just improve training overall in cancer care? Dr. Iyer, do you want to comment first? And then Farshid, I'll go to you too.
Sure. I think you hit on the main point, which is creating awareness, and some of it doesn't come just with the amount of or the deluge of news that we are surrounded with, and it's very hard for people to sort out what is real, what is not real. I think the education part has to, not just create awareness, but also lead sometimes, people by hand. And I'll give you a simple analogy. And we're in Houston, and there are two organizations and two contrasting approaches. It's election time in Houston. And I mean, I'm sure everywhere, right? So, but you should see the amount of political awareness that's in the community and the amount of drive to elect a particular candidate. And who is the most active in these areas? It's the Asian community, the South Asian community in particular. You look at the names, look at the candidates, look at the campaigns that go on, and it's successful, and people do get elected. But if you look at the other side of the equation, we have a network in Houston. It's called Indo-American Cancer Association Network, which tries to provide care and solutions for people with cancer, and they do work with some of the preventive care with MD Anderson. There are folks at MD Anderson who do this outreach areas with various communities, but the enthusiasm, the support, the funding is not quite to that extent that you see in the political campaign. At one point, we went to one of this awareness in the elections. The entire lineup of the officials in the Fort Bend area were available to meet all the people. There were about 250 people who showed up. On the other hand, I don't go to all the meetings in IACAN or to other preventive care. So I think it has to do with creating the awareness and having the support. And I really think that, MD Anderson right behind me, I think trying to make this happen and push this initiative. And one strong example is the SAHI, the MSK South Asian Health Initiative, which has done some work, which has done some enormous work in trying to create this. So it's awareness, trying to create this sense of education and not fear. I mean, that's the big thing. You want to create awareness as we're doing it. At the same time, say that these are preventable. I always show this Bert Vogelsteinian approach of cancer. We are tackling things here, but if you do things early on, like cervical cancer, you are able to save lives. And what are the health measures that you can take? The third thing is education. So there's also, and I think this is something that Dr. Shariff-Marco and Nishith may want to comment more on the educational level, because there's a different set of practices for people who are educated and people who are not educated. And people, and when I say not educated, may not have the level of sophistication to understand the complicated issues with the cancer, and they may come as a community. So there's one person in the family who's guiding them all, and maybe the right information, maybe the wrong information. So all these dynamics have to be, looked into.
Yeah, absolutely. As a person who's been that contact of in a family where, complicated cancer terms are used for diagnosis or staging and treatment, when other names of the treatments themselves are so complicated, and how do you understand what that's going to really end up in terms of what are the effects that you're going to feel or the patient's going to feel, and that's what they're focusing on. It is an absolute challenge. And personally, I'm lucky enough that I've had that cancer background and that knowledge, but in my family, I even struggle to translate that to be like, what does it like concretely mean in terms of what they're going to interact with? So that's definitely a struggle. Farshid, you wanted to talk a little bit more about community and organizations and how they.
Yeah. So in our community, going back to that outreach and awareness campaign, I think, as just said, sometimes throwing around, as Dr. Iyer just said, like using terms that are not readily accessible for everyone in the family, that's a big barrier in and of itself, right? But if we can make that awareness very pertinent to their own circumstances. For example, a lot of these migrant families, they come to the US later in their lives, right? So in the early part, when they are back, in homeland, they are exposed to environmental toxins, for example, in areas they used to reside in through their work, for example. Or, for example, you have industrial releases, smoke releases, sludge releases, and they have been exposed to that. And through their diet, because, for example, we do a lot of fish, we have a lot of fish and fish, derived products in our diets. So what happens is you have all these additive effects, chemical additives that sort of accumulate over the years, right? Now, what happens is if we can make these awareness campaigns specifically relevant to how they have used to lead their lives and how they can change their lives. For example, we have a lot of pakoras, fried food in our diet. But what happens is because of resource constraint, we end up reusing oil to fry this food. But if we can make them aware, and by extension, again, going back to what Nishith had said, Dr. Salma has said, which is sort of destigmatizing that, of course, this is not a contagious disease. This is something that you can actually, treatment is available. It's something that actually can happen to everyone. Going back to what Professor Marco was saying, that, the model minority means, for example, it has this effect, the ill-intended effect, which is we end up thinking nothing can really affect us. We are a resilient community. Again, going back to this resource constraint upbringing, where we think that, yeah, we can always wing it through. Nothing can affect us. So if there is a way we can make these discussions that it can happen to everyone, and there are certain ways we can impact ourselves in a positive manner by just changing how we lead how we come and what we eat, how we prepare food, and of course, annual screening, timely screening. Because that's another one. We have one of the lowest rates of screening when it comes to colorectal cancer. It's one of the studies that we did with Professor Shariff-Marco and Professor Mukherjee. So yes, I think we can get very creative and in a very fruitful, meaningful manner.
Salma, did you want to add to it? I saw that you're.
Well, I am trying to think about how to put this out there. I mean, I think that you can see the complexity here and all the different facets that we need to understand and address in order to improve, lower cancer risk and reduce sort of worse outcomes, right, from when our communities get cancer. And I think, you see my background here saying the word aspire. I'm just going to put a plug here for this new study that we are launching called the Aspire study. It's an Asian American cancer etiology study that is open to all Asian American ethnic groups, right? Our idea here is that our data has yet to be represented in cohort studies for cancer. We don't fully understand all the unique risk factors related to our immigration experience, related to our lived experience here in the US. And so we are just starting this study and keeping in mind that we are not restricting it to the largest groups or the groups on the West Coast or the groups on the East Coast. This is a national study. We want as many people who are willing to participate to join us. And we are trying to also have representation of all these ethnic groups, including the smallest ones, right? I think in epidemiology, unfortunately, sample size constantly drives us in order to be able to, have valid results, reliable results. But I think within epidemiology, we're moving to developing better tools to leverage data from small populations in unique and innovative ways so that we can still have people represented in studies and still report back from the important data, the valuable data that we collect from them and make them no longer invisible. So I'll drop the website in the chat. Just if people are curious, they can go check it out. They can sign up if they want to help. But I think it's, in the United States, NIH funding has gone to support, less than 1% of NIH funding has gone to support Asian American health. Asian American, I'm not even talking South Asian. So you can, guess what percentage of that is representing us, right? And is allowing us to have data. I think the other part of this is advocacy. So, part of the delay I mentioned earlier about us getting registry data out to characterize the burden of cancer in South Asian populations as well is the denominator data. So to calculate, to understand cancer incidence and mortality, we need denominator data, and we need it for these disaggregated groups. And that has been really challenging to get from the 2020 census in a reliable form. So I think we're doing some methodological work, checking different sources of denominator data. We're hoping this spring or early summer, we'll have some updated results for folks that, can help them understand sort of what the numbers look like when you use different sources of denominator data that's disaggregated and how reliable, we're going to put it all out there and let people decide. But I think this is another point of work that we as a community can do is to advocate for better data collection, even in terms of population data.
That's fantastic.
This is a very important study, and it's congratulations for putting this together, Dr. Shariff-Marco. I think I was just looking at the website, and I think the way I look at it is, as someone said it, known knowns, known unknowns, and unknown unknowns. I think we have so many unknowns here. And how do we get the data? How do we get the denominator to make recommendations and create that awareness?
Yeah, absolutely. And that as a great jumping point to understand, what are the current legislative and regulatory efforts that are underway to address cancer prevention and how South Asian communities can engage in advocacy to focus on prevention and understanding and providing better care and more impactful care. Nishith, do you want to comment?
Yeah, I can jump in on that. And I think I would just kind of take your question. I'd take a step back from that. And there are definitely legislative proposals to improve cancer care in communities of color and South Asian communities. But I think the biggest thing to keep in mind right now is that healthcare is under attack from the U.S. government. The U.S. government's attacking its own healthcare programs. Let's be very clear. So I think before we get into what's happening now, just kind of think back to ACA passed in 2010. We've had a couple changes in administration then, and based off who's in the White House, the amount of outreach, the amount of navigation services, the amount of publicity around enrollment in marketplace plans and enrollment in accessing Medicare, Medicaid, healthcare programs broadly, that ebbs and flows. And I'll leave it at that because we're a nonpartisan organization, but there's no consistency, there's no reliability for folks to know when and how to get healthcare. And that brings us to present day where I think they might even be taking the vote right now there's a proposal in Congress that would cut $880 billion in the Energy and Commerce Committee in the House, which they are directly responsible for Medicaid and Medicaid authorization and spending levels. So there's a lot of talk about how Medicaid, Medicare, Social Security will all be protected, but the Nonpartisan Congressional Budget Office came out with an analysis, I think about 2 or 3 weeks ago now, where they said there's no feasible way to cut that level of money without making drastic cuts to Medicaid. And that means millions of people are going to lose access to health insurance. That means without health insurance, lose access to screening and prevention and treatment, of course, but you're really stopping any kind of steps ahead we could take to not only prevent cancer or even treat cancer, but just treating cancer early when it's more treatable, more survivable. And frankly, from a kind of fiscal perspective, if you're looking at that, it's cheaper. You're making it more expensive for people to get treated and more likely that they will have long-term complications if not survive their treatment. So I think that's the biggest thing in terms of just kind of the threat landscape and accessing and maintaining healthcare. And the other thing, and I know Salma alluded to NIH funding doesn't really go towards the AAPI community, or NHPI community, I should say. But I think at the same time, we've all hearing, reading, seeing about the cuts at HHS and NIH, and thousands of people terminated without cause just about a week ago now. And between the court cases, between the kind of back and forth that's happening in the administration, some have been hired back, some have been laid off again. Some don't know because they haven't gotten one word on the other. But that really has an impact on public health broadly, because a lot of those researchers were doing research. I mean, most of the ones that were laid off were doing research in communities of color and anything quote unquote DEI or woke impact that the White House or HHS thought they had. They were looking at the disparities, which no one wants to talk about, despite the fact they are well documented. We all know they exist. And even outside of that, outside the researchers, the folks at HHS who are just administering programs, who are making sure the system runs smoothly, a lot of them have been laid off as well. So even if the system is there, it's set up to fail at this point. So I think those are two big things. And I know we talked on data disaggregation a couple of times now, so I'll just mention that's another factor is how we're counted. Salma talked about the 2020 census. And just think back to COVID, it was 2020 peak COVID time. And in that census, communities of color were noticeably and significantly undercounted as it was. So while we're still waiting for this data 5 years later, we already know that we're starting at a disadvantage because of how the counting was not done. But I know there's a lot more to say, but I'll stop there. So I don't want to monopolize time. So.
Yeah, there are definitely a lot of barriers at the current moment preventing it. I want to pivot to talk about what are some of the examples of successful community and or family engagement that have, or culturally tailored interventions that have made a difference in caregiving and in the process from screening to treatment. Dr. Salma.
Yeah, I think we've done a few, many programs, and as I mentioned, the MD Anderson has been engaged with various communities in Houston as a very, I can use the word heterogeneous. It's a good synonym for the different kinds of people in the community. And so we engage with many of them. And I'll give you a good example in the treatment area. And it's a good examples in screening and colorectal, and so they do a lot of 5K races and boot to end cancer. So all those things create awareness, and at the same time they have a community outreach program. But a more specific program is, since I deal with patients with blood cancers, and bone marrow transplant is one of the potentially curative options. One of the biggest problems, and it's been a problem that we've been working with for many years, and we've used IACA to engage, is to find donors, because for a bone marrow transplant, you need a donor, and the donor has to come from the family or from somewhere within the community, if you will. And the South Asian community has the lowest number of identifiable donors. So now it's a different situation. We at least are able to do what's called as half donors, haplo matches, and that changed from a series of innovations that happened in transplant care. But when this happened, we had to literally, based on where the patient came from, there's a person who was very passionate about this and had the plan to go to churches, go to mosques, And I would go and speak at these events, and many of my colleagues would go and speak at these events and speak to them in the language, speak to them in Hindi, speak to them in Urdu, speak to them in a South Indian language. And it's one advantage that we all have is we could speak multiple languages and also, relate to the people and encourage them to, of course, this is partnered with the NMDP, which is now called Be the Match. And so they would have volunteers to come to these sessions, and they had this event where a lot of school kids could also run these programs and couldn't have cheek swabs done, so they can then send the testing, the DNA testing done at the either the Red Cross or the Be the Match, and they can be part of the registry. So we've also done NPR programs, and these are community-focused programs, which is very successful. And several examples of patients who couldn't find donors, whether it's a Filipino donor, I'm going beyond South Asian community, or a Vietnamese donor, or a Pakistani donor. I think we've been very successful in getting someone that is close match for this. I think the same principle can be applied to primary prevention as well.
Farshid, did you want to add?
Sure. So part of the interventions, and Dr. Iyer, you're amazing. You covered a wide breadth of that. I'll go a little bit specific to, for example, not just, let's say, legal permanent residents when they first come over, when they immigrate here. But for example, when we have community members coming as students, for example, F1 students, or the skilled labor categories, H1B workers, for example, you will find that in a lot of the cases, their significant others, they come with the dependent visa category, and depending on the administration, sometimes they can work, sometimes they cannot, and that directly impacts what care they receive. So what we have been doing in our community is actually, we have doctors, internal medicine specialists, or psychiatrists, for example, or even, pediatricians. And we usually try to connect family members to our, anyone who's willing to help, especially when it comes to, let's say, anywhere from any complications. So it could be cancer related, but it could be as simple as, primary care, for example. So if we can do that effective liaison connection, what happens is then care can be received in a timely fashion. And then, of course, in a long-term sense, and this goes back to what Nishith was saying, where Medicaid starts coming in, or what the equivalent for our California, Medi-Cal. And the big part about that is this anticipated cuts will essentially directly impact our communities, because it's really directed as anything that has to do DI programs, right? And this is an impact, it's an option of that. So other areas where community engagement has helped, and this is for in palliative care, for example, where you will find that our community members are called upon to, if there is somebody we know who can give something that's more culturally relevant care, because as an example, one of our members, she had liver cancer, and she's already in hospice care, but what happened, she used to require, for example, pan at certain intervals, and we used to have, her son-in-law used to make it every lunch. He used to take time off, come home, but our community was trying to see if people could go and give her mental support, talk to her in a way where she wouldn't lose hope, for example. And so all this sort of, if there's a way, language matters, somebody who speaks that language, but at the same time, somebody who's also a little bit well-versed of what the patient needs in their language, in their culture. But if there is a way we can, I know there's all this sort of crowdsourced way of doing things, raising funds, but if awareness can go in that same direction to see that, it's not just a matter of, you do the likes on Facebook and that's the end of the story when it comes to transmitting information, but also actually if there is a way we can share information about each other, about each other's needs. And I think our communities can come together in that sense.
Thank you, Farshid. And I agree. I do think that our communities can come together. Selma, I have one last question for you in terms of just the prevalence of what is the genetic inherited risk when it comes to South Asians, especially where you said breast cancer is really prevalent within South Asian women. What's that genetic inherited risk? And then in terms of prevention, how important is it that people get the not just mammogram screening, but more of a genetic inherited risk assessment?
So I think I don't have data specifically for South Asians on, exclusively parsing it out by genetic, but in general, right, we say 90 to 95% of cancers are caused by lifestyle environmental factors. So you can see, I wouldn't expect that to translate too differently for the South Asian population. So I think that it's important for each of us to understand our risk factor, the risk factors, our genetic risks, plus other risk factors that we have as we, so that we can think about where can we cut back, what can we do better, where can we improve. But my bias as a social and behavioral scientist is that the bulk of what we need to do is address lifestyle factors, environmental factors. With that said, not necessarily only at the individual level, right, or at the family level. I do think that there are things that, that are the structural and social drivers. And so it's this combination of having to tackle these risk factors that are occurring, and not just putting the onus on a individual or a family, but really coming together and working as a society to address the things so that we can have health equity.
Yep, absolutely. I know we're coming close to the end of our session, but in terms of closing thoughts, if each of you, and I know some already shared this, can share what's your vision of advancing cancer prevention, especially within the South Asian communities, and what are some actionable steps that people can actually start to take to advance that prevention or intervention, and what are some resources that could actually be impactful? And I know awareness comes off as the main theme when it comes to cancer and reducing that stigma. But Dr. Iyer, I'll start with you, and then I'll go to Nishith for.
Sure. I think I had three things in mind. One is we talked about awareness, policy. I think the advocacy has to go deep down into engagement with the government. I think Nishith talked about the varying stances of various administrations. I think the healthcare it's not a stock market, it's not a trade policy, it's the health of the people. So I think it has to be the same no matter what. So I think that engagement is to be important, and whether it's going to have a series of ways to actually make the policy work towards the direction is important. Second is to, you have to have a long-term vision for it. Texas, for example, is the first one to start with the idea of eradicating cervical cancer. And 2012 is when they started. Australia started at the same time. They lost steam, and today the cervical cancer risk is still extremely high in Texas. Australia, on the other hand, is going to eradicate cervical cancer by 2030. So you need to have the long-term vision. Second is the creativity, right? If you talk about cervical cancer, I mean, is everybody willing to undergo a pap smear? It's a question we asked in our study in India, for example, when Naomi was involved in this study with the tribal area. Have absolutely no educational awareness, and the WHO was fantastic. Dr. Partha Basu, who's the head of cancer screening at IARC, made this happen. Part of this was to try and come up with a creative solution to this. Cervical cancer is caused by a virus. If the virus is present, and especially as self-sampling and the vaginal swab, which can be in something that the woman can do by herself, it's a much easier approach to do. So we screened 7,000 women. The infection rate was 8.8%. All we had to do is take care of the 600, 700 patients to do pap smears, and the rest of the 6,000 women didn't have to undergo those pap smears. here, the American Society of Gynecology, they still insist on pap smears. They've not given up on the HPV screening. So these are guidelines, and guidelines we think, and I know we're in the guidelines committee, they're written in stone. They don't have to be written in stone. You have to look at the populations. When you go to Texas, you go to El Paso, when you go to these underserved community, you can't use those guidelines in the Indo-Indian reservation area, right? I think the third
Absolutely.
thing, and the third thing I want to just end this and say, I think one of the ambition is to have a genomic. We have the 23andMe, and everybody wants to find out the ancestry. But I think that's a way for us also to find some cancer predilections. You ask a question. I think that may be one other engagement.
Absolutely. Nishith?
Yeah, I'll just kind of build on that. I think advocacy, I'm coming from an advocacy background, and advocacy world, so I'll really focus on that. I mean, I talked about the impact of Medicaid and kind of what's happening with political wins in healthcare. And I think HPV vaccination is a great example of that. We have a Secretary of Health and Human Services who's been known to be anti-vax. We had a CDC director nominee who was known to be anti-vax, who's since withdrawn. But I think vaccination plays a key role in a lot of diseases, including cancer. And we saw downtrends in cancer for the first time about 3 years ago now. But and those due to HPV vaccination, and that led to reduction in cervical cancer. So I think advocacy matters, your voice matters. And if you want to get involved, I think we have a very, what I think is an easy way to get involved from our website. It's fightcancer.org. If you go to take action and click on actions, there's various, it's a pre-fill, you fill out your name and address, and it pre-writes a letter to you for your members of Congress. And you can make your voice heard and let them know you care about Medicaid, you care about vaccination, you care about funding, or whatever the issue may be. There's a variety of issues up there, but I think it's hard for people to know how to approach government if you haven't done it before. So we really want to make it as easy as possible and just get out there and make your voice heard, both at the ballot box, of course, but even day to day. They need to know what people on the ground are saying. So
That's fantastic. Fantastic. And Farshid,
And
close this out.
Nishith and Dr. Iyer pretty much said a lot. Enough. It's amazing points. Just I'd go on the mental health side of it, because each condition has the other side. You need mental support. You need an environment where the patient feels they're empowered, and the community, by extension, feels that there is treatment available, and by extension, there are preventative steps so that you are not in that shoe. But closely aligning with that, which is what Nishith and Dr. said, which is the word has to be spread out, and advocacy is a big one for that, because cancer affects everyone regardless of race, creed. So if we can make that heard, especially when it comes to Medicaid cuts, and make sure that not, our voice is heard, so that how do we get it, to the attention of the relevant authorities, that if specific sections of the society are involved, it doesn't mean only that section of the society. Everybody is getting it. So yeah.
Absolutely. And that comes to a closing time for us. But thank you all for joining. And thank you so much to our panelists for enlightening us in all the areas of, prevention, care, policy, and advocacy, and community engagement that the South Asian community can actually first be aware of, but also start to get involved and learn to take action from as well. I'm sorry I didn't get to go through all the questions that if anybody has on the chat, but please share with us if you do have any questions, and we'll make sure to get them answered, and we'll definitely be including them in our cancer toolkit that will be coming in the next few weeks after, which will include a recording of this webinar as well.
Thank you. Can I just email you my questions? I didn't get a chance to put it in the chat.
Absolutely.
Okay, thank you so much. This was really helpful. I really appreciate all the panelists' time.
Thank you so much for joining, everyone.
Thank you.
Thank you, everyone.
Thank you.
As a plug, just check out our website, www.sapha.org. If you subscribe to our newsletter and if you've signed up using the Zepi link, we will be emailing out a recording of this webinar as well as the toolkit. If you have any questions in the meantime, send us an email and we'll include an FAQ in the toolkit that will cover your questions. Thank you all.